Most healthcare organizations have accepted that value-based reform under the Affordable Care Act means optimizing the relationship between what they are selling, healthy or improved outcomes, with the cost of delivery. So what I'd like to do is start with you, Mike, to discuss traditional models of care and payment, fee-for-service, chemotherapy buy and bill, and maybe some of your thoughts about new models, where we are and where we need to go.
Sure. So all of us are of an age where we have lived through the migration initially of cancer care from the hospital setting in the 80s to community-based office practice in the 90s, and more recently some migration back to the employed physician model. Throughout this period of time, reimbursement both for Medicare and for the commercial payers have been largely based on fee-for-service, or what is proverbially called pay for volume. And chemotherapy has been generally paid on an invoiced basis, where the provider, doctor, oncology office purchases the drug from a GPO or pharmacy provider, and then administers the drug, and then passes on the cost of therapy in a cost-plus fashion to the payer. And boy, I wish I had a nickel for every time I had to defend buy and bill. I lived through that system. We worked very hard to make that system work as a business model for the practice in the years I worked at U.S. Oncology. The system is problematic insofar as it creates the impression of conflict, of conflicted interest. And hey, listen, the infrastructure that a practice has to build in order to deliver high-quality care in the office, which is paid for predominantly by the margin on injectable drugs, is very, very complicated. There's been multiple studies looking at the overhead costs of medical practice, and oncologists is number one by far and away. But because of this perception of perverse incentive, there has been a continued erosion of the way chemotherapy gets reimbursed. Whether it's right or wrong, I think we are getting to the point where people are getting very uncomfortable with the idea that a practice should make more money just because the woman has HER2-positive breast cancer. I mean, that's a little bit crazy. Not that taking care of a patient with HER2-positive breast cancer is necessarily an easy thing to do, but that patient is certainly not any more complicated than a triple-negative breast cancer patient. In fact, often quite the contrary. So the buy and bill model, which has funded the infrastructure to allow community practices to perform, I think is in jeopardy. Now, the problem, though, is we can't just, as some of the people in Washington, D.C., and in the payer community think, we can't just, with the stroke of a pen, eliminate it, right? Because what will happen is that, well, first of all, it'll be my last day on the job, because the oncology care delivery model will collapse. It will collapse. There will be, talk about access problems, there'll be no place for patients to go to get treated, right? So we have to somehow migrate from that model, which we've become uncomfortable with, to a model where we pay oncologists for doing a good job.
I think we've mentioned two different things. We've mentioned fee-for-service, we've mentioned buy and bill. I think you have to understand that the two are very much related.
Absolutely.
And that's because it's not really fee-for-service, it's fee-for-some services. And so we are paid for doctor touches. If I touch the patient or the patient gets infused, the clinic gets paid. All the rest of the things we do don't get paid for at all. So we don't get paid for nutrition consults, social worker consults, financial counseling. We're paid very poorly for the education process and the consenting of patients. There's all these things that we aren't paid for, and how do we do them? We do them because there is a margin on drugs. And we take that margin and we use it to do all those things that our patients really need and value that nobody pays us to do. So if you're going to get rid of buy and bill, and I think that it's going to happen eventually, then you need to turn around and say, okay, we are now going to reimburse for what an oncology clinic, not what a doctor does, but what the oncology clinic does. And then you have put yourself in a position to say, okay, now we're actually paying for the medical home that Mike is enamored with.
So I think